Hello.
Go ahead,
Those of
take it
us.
away.
I'm Rima. I'm an R2. I'm in the ClinEd pathway, which gives me the wonderful opportunity to speak to all of you about a topic near and dear to my heart. I will be applying into geriatrics eventually, so most of my interests lie in the outpatient world, but hopefully this provides information for everybody. Those of you who stuck around the break got to hear about my love of Awkward Yeti, and I got to learn about a game that I will be asking Santa for, so thank you. Oh, and now we're not advancing. Come on, there we go. I have no disclosures other than the fact that I've taken one endocrinology elective, and it kind of changed the way I think about insulin resistance and diabetes management. So I'm not an expert, but I find this very interesting, and I learned a lot more while reading and preparing for this talk. So hopefully by the end of my allotted time, learners will be able to summarize and critique the diagnostic criteria that we have and is taught in medical schools for prediabetes. We will briefly touch on the pathophysiology of impaired glucose tolerance, and that is my preferred phrasing moving forward over prediabetes, and I hope to explain to you why using this multi-stage model. I'm going to talk to you a little bit about vascular complications of impaired glucose tolerance that I think I conceptually thought were associated with diabetes, but again, I hope to show you that it happens earlier than we thought. And then we will put this all together in some practical recommendations and evidence-based interventions to prevent further progression. Okay, so I think that my first slide is a surprise to nobody. There's 3 diagnostic criteria for what we consider prediabetes. The one that's bolded is A1C, because I think it's definitely the one most familiar to me and probably to all of you. I know what that number means. I know how it correlated with the pathophysiology. And I've been pimped on this chart on the right, go New York Medical Schools, about what level of glucose correlates with each A1C, but I will circle back to that in a second. The other 2 criteria, you can use fasting glucose, which means folks are not supposed to eat for 8 hours, generally overnight for first thing in the morning testing. And there's a glucose tolerance test that involves taking 75 grams of oral glucose and measuring their plasma glucose 2 hours later. They also have to fast for 8 hours before this test. The reason I've put this table here is because I've been told to memorize this, but it turns out it's not that accurate. They studied recently what mean A1C is in different populations, and it turns out it can vary between 0.15 and 0.4%, which is pretty large. The study I read adjusted their analysis by age, sex, education, marital status, all those things you see in the middle of the slide, and still like 78% of the variance was still not explained. A subsequent paragraph in the study said that they tried to adjust for degrees of access and care, and it was still not explained, although I don't know what they did because they kind of glossed over that. And then they tried to speculate that perhaps there's differences in things like hemoglobinopathies and anemias and things that differ from ethnicity to ethnicity. But we don't know what that is, and there's no study. So all of this is to say that there's some variation in A1C, and we don't really know why. So there's further studies to be done. And then the second study I wanted to bring to your attention is in sunny California, where I currently am. They looked at several outpatient centers, and they counted up all the patients who qualify for prediabetes using any of the 3 prior criteria. And then they looked through the EMR to see how many of those are actually appropriately screened and diagnosed by their provider, and only 37% are. And being male, being Black, and having certain comorbidities involving immunosuppressants or iron supplementation were correlated with not being appropriately screened and or diagnosed. So something for us to be aware of moving forward. I'm going to do this very quickly because I think this is hammered into us in medical school and residency, but very quickly, our glucose levels during a fasting state are mainly just the interplay between how much insulin our body is producing and how much glucose our liver is churning out, and that's called endogenous glucose production, or EGP. Right after we eat, it's a little bit more complicated. The EGP should be suppressed because you are taking in glucose from your intestines. And then insulin sensitivity and insulin secretion are inversely related to one another. We previously thought that the interplay of glucose dysregulation, insulin resistance, and beta cell dysfunction happens pretty sequentially, but I hope to make the case to you that these things happen in tandem and much earlier. Folks who develop impaired glucose tolerance do not suppress EGP the way normal glucose tolerance or NGT folks do. I think the case for insulin secretion and insulin sensitivity being off kilter in diabetes is not a surprise to you. And then fasting insulin is also thrown off by this process, and we will talk more about that in a second. So instead of talking about rising glucose as the starting point for diabetes development, there's this multi-stage developed by Dr. Weir, that multi-stage model developed by Dr. Weir that I think is very helpful in choosing our next steps. So there's 5 steps, and the first one is a period. And I like the language that compares it to other states that we consider compensated and decompensated. So at first, you have some insulin resistance. Your glucose signaling is dysregulated. To compensate, your body makes a whole lot more of insulin, just like my lovely cartoon at the beginning. My phone's talking to me. Oh, I'm echoing on my phone. Sorry, guys, 1 second. I'm just going to leave my other device. Okay. And then to facilitate extra insulin secretion, your pancreas beta cells increase in quantity, and they can see that in postmortem studies. At some point, your beta cells can't quite match it, and the insulin secretion rate begins to plateau. And this period of time, as you can imagine, is not that long before your glucose levels begin to rise, and this is the unstable stage. Beta cells begin to de-differentiate, and there's a lot of interesting biochemical papers about this that is beyond the scope of our discussion, but if you're interested, there's a ton, and one's linked at the bottom. And then I just need to move your lovely faces over so I can read the right side of my screen. Eventually, you become severely decompensated, where the beta cells de-differentiating leads to a marked loss of beta cells altogether. This happens years down the line. Typically, folks are in their 70s and 80s and have been battling insulin for a long time by the time their pancreas kind of loses steam. If you are purely relying on A1C, the way most of us are taught, this is the stage in which you start to see manifestations of what we call pre-diabetes. Your A1C has risen because your hemoglobin's being glycolated. And then anything beyond that is what we consider full-blown diabetes. But there's all this stuff in the beginning that if we can measure, perhaps we can intervene on and prevent progression down this model. Move your faces back. Okay. So in the early stages of impaired glucose tolerance, we see some of the downstream effects that are associated with diabetes, even at normal A1Cs. You see a nearly 3-fold prevalence of unrecognized MI. You can see increased arterial stiffness. And then interestingly, even a 1% increase in A1C has a 28% increase in 10-year cardiovascular mortality. And that difference, not quite at 28%, but a statistically significant one, persists even at A1Cs that a lot of us gloss over when we get labs and think are perfectly normal. And these are, I think, pretty staggering numbers. Similar things happen in the kidneys. On the left, you can see unadjusted figures, and on the right, adjusted by race, gender, and race/ethnicity. Obviously, this is partly compounded by things like concurrent hypertension or dyslipidemia and cardiovascular disease that we saw on the previous slide, but you still see, it's driving me nuts that these graphs are right to left instead of left to right. But anyway, a statistically significant increase in association with CKD in folks who have normal glucose tolerance and impaired glucose tolerance. I've included the USPSTF recommendations for screening to point out a couple things. One is, when I was in medical school, the recommended age was 40 to 70, and it's since been dropped to 35 to 70. And specifically in folks who are overweight or obese, so BMI of 25 or greater. And to point out a few other things so that we're really not falling into the trap of screening some people and not screening other people. There are some populations that have disproportionately higher incidences of this disease, and they're listed in the middle. And I think getting a really good family history to see who has folks with diabetes and first-degree relatives and screen those people sooner. Gestational diabetes also predicts development of impaired glucose tolerance down the line in non-pregnant states, and a history of polycystic ovarian syndrome similarly is associated with development of metabolic syndrome and impaired glucose tolerance. And then Asian American people have risks at lower BMIs, such as 23 is recommended by the USPSTF. So those are the peoples we should screen. I just told you that A1C is not that useful. So what is? Emerging research and more endocrinologists are using A1C secondarily, but the most robust screening test is fasting serum insulin and glucose levels, which you should collect at the same time. One model showed that if you catch people whose fasting insulin levels are greater than 9, then you would catch a good chunk of them. Before I talk about how to intervene, I'd like to pause and ask if anybody has any questions because I can't see the chat. Okay. So
is measuring insulin something you routinely do in clinic, and is it fairly easy to interpret for primary care providers?
I didn't until I did this endocrinology rotation over the summer, and all of the endocrinologists do it. So I've started doing it. Truth be told, I've done it on 2 patients, but theoretically you can do it. And it spits out a number. And I generally use, the trend is very helpful because if it's rising over time, you can tell that they are developing worsening impaired glucose tolerance, but 9 is a decent threshold to intervene on.
Cool, thanks.
Okay, so if you see rising fasting insulin or frank A1C increases, these are some evidence-based interventions that you can recommend to your patients. I have a lot of anxiety about talking to patients about lifestyle changes. I don't want to feel like I am attacking anybody's schedule or habits, or obviously people are very sensitive about their weight. So I find that if you have specific recommendations to tell people, instead of just like, hey, change everything about what you're doing and eating regardless of your income or work schedule, this is perhaps a little bit more easy. The research shows decreasing your weight by 5% of initial body weight is associated with better outcomes. Some people who are like very numbers happy, like me, I might share that number, but I think the others are more useful. Decreasing your fat intake by 30, having good fiber for GI health, and then really the kicker is increasing physical activity by more than 4 hours a week. And when I initially saw that number, I looked at my smartwatch and I was like, I'm not hitting that. But briskly walking with your dog or your children or around the block or rounds, if you are one of us, counts as brisk physical activity. So I think if you totaled all that up, that is not that difficult to get. About half an hour a day is associated with better outcomes. The medications like metformin have been around forever. They're very cheap, very effective, and generally very well tolerated. They help with weight loss, so it helps with the previous step. It also decreases dyslipidemia and reduces your fasting glucose because it increases insulin sensitivity. Some people report more GI distress with higher doses. So as you're titrating up, whatever is the one that they can tolerate is the one that I stick to. And then alpha glucosidase inhibitors, I really hadn't thought about since step 1. And then I see a lot of endocrinologists using it in this impaired glucose tolerance stage before people have progressed to, quote, full-blown diabetes. This is the like diuretic of the glucose world. It prevents you from absorbing breaking down polysaccharides into glucose, and therefore you're not absorbing them. Predictably, this causes a lot of flatulence and GI distress. So people don't like them. I think a full third of patients did not complete the trial in many of the papers I read, but 2/3 people did. So if folks can, it works really well. GLP-1 analogs like semaglutide are the Vogue kids on the block. They are new and therefore expensive, but if it's within the ability of your patients, it helps with weight loss. It's in fact FDA approved for weight loss without diabetes, so you can get it for patients, and it's sometimes covered by insurance at the VA. It's very easy to get. And then there's also insulin secreted, I can't pronounce this word, like repaglinide. That's also very effective. Because I'm at the VA, I'm most familiar with the VA's resources, but I'm sure there's something similar to all of them. The VA has a program called VA Move, which helps patients form a community around these lifestyle changes. And I have several patients who really, really loved it. And in some cases, you have to enroll the patients in VA Move in order to get them qualified for medications like semaglutide.
Rima, real quick before you move on, we had one question pop up in the chat from Austin about how often we're repeating screening for patients we're concerned about a screening's normal to begin with.
Happy belated birthday, Austin. Yes, I have a slide on that I will get to. Any other questions before I move forward?
Just some comments. Apparently, Luke tells us that Japan uses way more acarbose than we do here. Up to 50% of patients with diabetes is what he's heard, and it's generally better tolerated in Southeast Asian populations for reasons we don't remember.
I do not.
So, fun facts for us. Lauren is asking, trying to wrap my head around how much to rely on fasting insulin/glucose. Is the test positive in 80% of patients with prediabetes?
Yes, I initially had a bell curve to explain that, and then it made it more complicated. It's kind of like blood cultures where the more you test for it, and if you see to start rise, that is more helpful, by which I mean the more you test for it, the sensitivity increases. So what I do is if I'm worried about somebody, then I check it maybe every 6 months, even though the official guidelines to check it annually, which is the answer to Austin's question and on a subsequent slide. And if I see it start to rise, then I might start talking to them more aggressively about starting metformin and lifestyle changes.
Great. And then had some questions just in general about things covered by insurance. John is mentioning that because we're using GLP-1 agonists increasingly for weight loss, there's increasing restrictions by some insurers and availability for them. And then also some conversation previously about concerns about whether or not payers are going to cover fasting insulin as part of preventative care, or if patients are going to have copays for that.
That is an excellent question. I am spoiled that I'm at the VA, and these things are very easy at the VA since it's the closest thing to single payer health system that we have in this country. But next time I'm at the adult medicine clinic, I will ask to see, and I will get back to you. And then there are increasing limitations on getting GLP-1 analogs in non-VA settings. And I think even at the VA, it's being slightly more difficult because it's like so many things, decreased supply of it. Very quick note on GLP-1 analogs. Like most of the meds on this list, it's associated with GI distress. So the lowest dose that drops their weight is the one that you stick to. And if they start to develop GI distress, then you just go right back down. Okay, there was this pretty big study called the Diabetes Prevention Program, and they showed that these things work. They showed that you can prevent or at least substantially delay type 2 diabetes, and you can decrease weight and the other things I'll get to. So the inclusion criteria for this study used either impaired glucose tolerance or the oral glucose tolerance test. Of note, they did not use A1C, which I thought very interesting and in line with the newer ways of thinking about impaired glucose tolerance. And you can see that the number needed to treat to prevent 1 case of diabetes at only 3 years is 7. single digit 7, and with metformin 14. So awesome. And I was very happy to see that this study was pretty diverse. A lot of other studies that I'll get to were not. Is my slide not advancing? Oh, there we go. Okay. So not only did it decrease improved glucose tolerance and decrease things like weight, it also showed reductions in other CVD risk factors like dyslipidemia and hypertension. And lifestyle, if people stick to it, and in this case, they used weight reduction of at least 7% via the aforementioned diet and physical activity, that it reduced better than metformin. Okay, so the answer to Austin's question is the general recommendation is to do these things at least annually. And if you are kind of looking for a trend over time, then 6 months to a year is also reasonable to do. The other things I don't want you to forget about is to continue talking to patients about reducing smoking or ceasing altogether if possible, treating hypertension, putting patients on statins if appropriate with risk-benefit discussions, regular eye exams. I didn't go into retinopathy because it led me down a tangent, but most of us should be seeing the eye doctor once a year, and these patients are no exception. Urine albumin creatinine is the earliest and most sensitive marker for nephropathy, so we can be doing that annually also. And then associated with weight gain and development of chronic illnesses, the prevalence of depression starts to rise. So you should be screening these patients using a PHQ-9 or whatever else is your favorite screening tool, at least annually also. Okay, I think I sped through that a little bit faster than intended, but the take-home points I'd like you to remember is that fasting insulin is a robust test to catch impaired glucose tolerance early. It's associated with increased risk of cardiovascular disease even before you start seeing increases in A1C. So there's an opportunity for us to intervene on glucose dysregulation. Take to patients to talk about specific lifestyle interventions, and you can refer them to things like the VA MOVE program as appropriate. Metformin is evidence-based. It's cheap. I just put my dad on it and he's thrilled that it costs like $2 a month. It's effective and generally well tolerated. And then you should keep an eye on its sequelae at least annually. Okay, I can see chat things kind of now. Are there any questions? These are 2 papers that I found very helpful in reading about these things. For anybody that would like to learn more about the ongoing research in this field. And then I would like to thank endocrinologist Samir Hafi over at Swedish Issaquah that I worked with over the summer and learned a lot of these things. Dr. Kim Cardancy is my ClinEd mentor, who's been sending me a lot of excellent teaching feedback and resources. And of course, Dr. Gabby Berger and the rest of my lovely UW ClinEd peers and teachers in this photo.
One question just popped up in the chat room, Ruth. Is prediabetes reversible to the point of being able to stop metformin?
I think so. I have seen patients being taken off metformin, but I have seen people stay on it lifelong more. Oh, I didn't know that, John. Even for Victoza, not just Ozempic. Interesting.
I'm not sure. This is brand new information. I think that this is a developing story, more to be learned.
The microbiome, the answer to all of our questions in science, the microbiome. Bacteria run our body. Thank you, Luke. Okay, in that case, I thank you for your time. I guess this means I gave you a bigger break than planned. But my email address that I meant to put on the slide is, I'm going to put in the chat in case you have any questions. I'm happy to talk about this for hours.
Thanks, Rima. I think no one ever minds a little bit of an extra break.